Hi, and welcome to JSCAI Conversations. My name is Andy Goldsweig. I'm Director of Cardiovascular Clinical Research at Bay State Medical Center in Springfield, Massachusetts, as well as Associate Editor of JSCAI, the Journal of the Society for Cardiovascular Angiography and Interventions. I'm honored to represent JSCAI and our Editor-in-Chief, Dr. Alexander Lansky. JSCAI is the home of all official SCAI documents. We're here today to discuss an important recent publication in JSCAI entitled The Impact of Intravascular Ultrasound Use on One-Year Outcomes After Infrapopliteal Endovascular Intervention. We have an esteemed panel of internationally renowned experts, including the authors. The first author, Dr. Daniel Snyder, a cardiology fellow at Columbia University in New York, New York. The senior author, Dr. Sahil Parikh, an interventional cardiologist, associate professor, and director of endovascular services at Columbia University. And Dr. Herb Aronow, an interventional cardiologist and medical director of the Heart and Vascular Service Line at Henry Ford Health in Detroit, Michigan. Thank you, gentlemen, so much for joining us. Very excited to discuss this paper with you. To start, I'd like to direct a question to Dr. Snyder. In this paper, you and your team describe a 4-year retrospective analysis of infrapopliteal endovascular interventions, comparing outcomes between procedures performed with and without intravascular ultrasound use. I'd like to ask you, if you would, please summarize your group's findings for our listeners. And I know that you prepared some slides, so go ahead and share them.
Thank you so much for having me, and thank you for the kind introduction as well. So I'll take you guys through our project looking at the impact of IVUS use on one-year outcomes after BTK endovascular intervention. I was the first author on this project, and Dr. Parikh was the PI. So I probably don't have to tell anyone on this panel, but recent consensus statements and expert opinion documents, including those published in JSCAI by some of the people on this panel, support the use of IVUS in almost all phases of peripheral endovascular intervention. And although existing usage rates across the US have been increasing, overall usage rates are actually fairly low, with recently cited estimates of about 4 to 5% for inpatient. And a need for further research has been cited as a barrier to more widespread adoption in recent expert opinion statements. And well, we have RCT data supporting the impact of IVUS use on outcomes in the FEMPOP circulation, including a study by Allen et al. Published in JSCAI a few years ago now, and more recently the IVUS DCB study. The data evaluating the use of IVUS in the BTK space remains relatively sparse. So this study aimed to address this gap in literature by evaluating the association between IVUS use and rates of binary stenosis and TLR up to 1 year post BTK intervention at our institution. So how do we actually do this? We performed a retrospective analysis of all BTK endovascular interventions at our medical center, really over a 4-year period from 2018 through 2021. We collected and compared data regarding demographics, clinical characteristics, lesion data, and procedural techniques as well. And the primary outcome for our study was binary stenosis, which we looked at 6 months and at 1 year. And this could be either greater than or equal to 50% stenosis on angio or on duplex ultrasound, which was a peak systolic velocity ratio greater than or equal to 2.4 as the cutoff. And the secondary outcomes of interest in this study were TLR, amputation, major adverse limb events, and all-cause mortality. So when you look at the results of our study, it was a 100-patient study with 142 lesions. And IVUS was used for 32 lesions, which is about a quarter of the study population in terms of lesions. It was used to treat the lesion on the right. It's kind of a longer peroneal lesion. You can see the IVUS shots on the far right of the screen, showing pretty substantial 360-degree calcification. And when you looked at the groups and compared them, there were no significant differences in baseline characteristics, including demographics, clinical comorbidities, medications, retrofit class, et cetera. Between the groups, and the distribution of lesion locations, the length of those lesions, the task classification was also similar. But notably, there were substantially fewer lesions with severe calcification in the IVUS group. And then when you looked at treatment strategies, they were similar with the exception that lesions treated with IVUS guidance had a higher frequency of atherectomy usage, about 22% versus 8%. There are also higher frequencies of other calcium modification tools like lithotripsy. Atherectomy was used to treat the lesion on the right hand of our screen. And I think the major takeaway can be seen in our Kaplan-Meier curves from the study, which we included in the central illustration of the paper as well. So if you look at the Kaplan-Meier curve on the left of our screen, it shows freedom from binary restenosis, with the red curve being adjunctive IVUS use or IVUS plus angiography, and the blue curve being angiography alone. And what you can see is that the curves diverge at really around 1 month, and then the divergence kind of gets greater in magnitude over time, to the point where when you get to 1 year, the rates of freedom from binary stenosis are substantially better when IVUS was utilized as opposed to just angiography alone. And the log rank P for that was 0.004, so pretty significant. And then when you look at the other Kaplan-Meier curve, which is on the right-hand side of the screen, that looks at freedom from target lesion revasc. And the color scheme is the same, and you see a similar pattern, although the magnitude of divergence is a little bit less, and it is kind of lagging behind the binary stenosis rates. But what you see is, again, a substantially better rate of freedom from TLR when IVUS was utilized when you get out to about 1 year as compared to angiography alone. It did not meet statistical significance, but was definitely a trend there. So, what are the major takeaways here? Overall, results of our study demonstrate that IVUS use is associated with significantly lower rates of binary stenosis and substantially lower rates of TLR when used as an adjunctive imaging modality during BTK and endovascular intervention. This study adds to the foundation of observational research that supports IVUS usage in BTK intervention, and they are concordant with what's been seen in the more prospective randomized trials that you've seen in the FEMPOP vessels that I mentioned before. Given the structure of our study, the results here are hypothesis generating, but they do show a pretty clear trend, and they support the need for an RCT that substantiates the impact of IVUS use and post-intervention outcomes after BTK PVI. So, that was kind of a highlights of our paper, and I'm happy to kind of get into discussion or answer any questions.
Fantastic. Well, thanks very much, Dan. That's a very comprehensive summary, and it's very exciting to see what you found. We always have concerns about biases in retrospective analyses, but it looks like in your analysis, first, both groups were very, very similar. And if anything, there was more calcification in the no IVUS group. So very exciting to see those findings. I want to direct a question to Dr. Parikh about how this information should be used. How should this knowledge change day-to-day clinical practice in terms of performing infrapopliteal interventions? How should we incorporate this information in terms of patient selection for IVUS and how to use the information we glean from IVUS?
Thanks, Andy. So it's a leading question, but I think that the first thing, as Dan pointed out, this is a sort of hypothesis generating kind of a study. We thought, since our center does a fair bit of CLI intervention, infrapopliteal is almost synonymous with CLI intervention. And we have a few practitioners that are IVUS aficionados, myself included, and some that were not using IVUS. So we wanted to look at our own data. And this was helpful in that it can potentially help us power a really prospective randomized trial, which is obviously something that we are ambitious about trying to sponsor and fund. The device companies have been reticent to do so, but we think with data like these, we can actually go to the device companies or as a society perhaps, and or with the collaboration of other societies, really try to do an investigator-initiated trial to demonstrate the value proposition. We've seen it in coronary intervention where we show really meaningful improvement in hard endpoints with the use of intravascular imaging, left main, for example, and similar lesion subsets. Here, the infrapopliteal circulation is sort of the complex leading edge, if you will, of where endovascular intervention is today. And we'd love to see IVUS improve our ability to, expand the patency opportunities we have there. We have new technologies, but we have old technologies that are underutilized that really could make us much better interventionalists and do better for our patients. The other thing that's, I think, really interesting is that there is quite a substantial difference that can be obtained by just using simple existing tools. You saw the curves are perhaps overrepresenting what difference might be in a prospective study, but these are very big differences that are statistically significant and diverge early. And so again, I think that early technical failures can be avoided by using intravascular imaging, which is something we would intuit as interventional cardiologists, but would be an opportunity for us to really kind of make an impact in how care is rendered. And Herb and I and others have been participants in appropriate use criteria documents. But many of those have really ignored the adjunctive imaging techniques. It's very focused on the widgets, the stents, the balloons, the medicated technologies, atherectomy, but it hasn't really focused on something really right in front of our noses, which is the use of imaging to improve our outcomes. So we're excited about these data. They're preliminary, they're hypothesis generating, but we think putting a flag in the sand will help move the field forward.
Fantastic. I can't agree more. I think you raise an important point about the challenges of establishing an RCT, especially in a world where the coronary data are very, very strong, right? IVUS XPL, Ultimate, Renovate Complex PCI, Illumian 4 for OCT, and still there's an RCT ongoing, right? Improve is enrolling to try to generate enough data and enough international data to establish a Class 1 recommendation. I wonder, in the peripheral space, particularly the below-the-knee space, with such strong coronary data and retrospective data like these, if an RCT is needed. What do you think?
Well, here's the problem. I think that to get a guideline recommendation, which we do think will drive user adoption, as Dan alluded to, we need multiple randomized prospective trials. Unfortunately, that bar has not moved really. Notwithstanding that, it also will provide a little bit of fuel to the fire that doing below-knee intervention with IVUS guidance is going to be useful. I think with the advent of new technologies, specifically drug-eluting resorbable scaffolds and drug-coated balloons, where apposition actually matters to get drug effect, sizing is a critically important issue, and we've seen that we're woefully inadequate at sizing these long, narrow caliber vessels with contemporary techniques. So, again, is it necessary? Not necessarily to get a level of evidence C kind of a recommendation, but that doesn't move the needle. The other real issue is that we all know, and the elephant in the room is that reimbursement drives behavior. We are a hospital-based practice, and despite that, we're using IVUS where it's not often reimbursed, if at all. And in the OBL space, where it is reimbursed, there's a higher utilization of IVUS because there's reimbursement. But that doesn't necessarily drive good behavior. So we want to make it so that there's a level playing field, both in the hospital setting and in the OBL or ASC, where there's strong evidence supporting the value proposition, both clinically as well as financially. So that's where the field's got to move if we're really going to change behavior.
Those are great points. Let me turn some of these questions to Dr. Aronow. The work by Dr. Snyder, Dr. Parikh, and their colleagues certainly argues very strongly for IVUS use to guide infrapopliteal interventions. So I want to ask you a two-part question, both issues we just touched on. First, what further research is necessary and is possible to increase the use of IVUS for these procedures? What can we expect in terms of research that can be legitimately performed in terms of having equipoise and being able to get funding? Beyond research, the second question is what measures are needed from a reimbursement perspective to increase the use of IVUS? Do we need guideline statements? Do we need a Class 1A recommendation? Do we need advocacy from professional societies like SCAI? Do we need action from payers? So what's the research we need, and then what's the reimbursement strategy we need?
Yeah, so I appreciate the simple questions. First of all, I want to congratulate Dan and Sahil on a really nice paper. I think it really is a nice contribution to the literature. It's a really important space, and so I think we need more data to build that evidence base. I think the point's already been made that we're not likely to see a major change in behavior without level 1 evidence. I happen to practice at a center where we use IVUS in almost every coronary and peripheral case, but I know we're an outlier. Now, we're all adhering to that seeing is believing philosophy, and there are others out there, but the majority, as you know, you've seen the statistics, even in your study that was published in JSCAI, the numbers are small. It was the minority of people who had IVUS. So I think that, yes, we're going to need to see randomized trials, probably not just one, but multiple, just like we did in the coronary space with hard outcomes, so that people understand that there's a benefit in return for this investment, right? So fast forward a few years, let's say, and now you have results and they support what we're hypothesizing. At that point, I think then you can talk about guidelines, right? And I think at that point, you can talk about professional societies advocating on behalf of patients to payers. I think in the meantime, it's unlikely that what we say, even if we really believe, and I do, that IVUS makes a difference in clinical outcome, it's going to be hard, I think, to convince the masses. I think, when you ask yourself, so what are the things that might increase use of IVUS in the lab, in particular in the situation with endovascular work? Cost is certainly part of this. My guess is there's a sweet spot somewhere that if you lower the price of the catheter, especially for inpatient work, where you're just eating that cost, right? That, if someone's an inpatient, then that stay is reimbursed under a DRG, a diagnosis-related group, and you can spend all you want, but you don't get paid anymore, right? So I think people are more and more operators are more and more cognizant of those costs, and so are hospital administrators, and so there's pressure not to use things that you don't know are going to make a huge difference. So I think if the price point comes down a little bit, that could lead to broader utilization of the technology. I don't think that the reluctance is necessarily just because we don't have level 1 evidence. I think it's because all those widgets you mentioned, Sahil, they all cost a lot of money and they add up. And in the end, you can't lose money on every case, or you can't keep treating patients, right? I think ultimately, if we see positive data from randomized trials, it would make sense to advocate for a broader coverage. That would be most important probably in the outpatient setting, right, where you're being paid for what you do during that specific procedure and not for an entire stay. But unfortunately, I think we're going to have to be patient. Most of us interventional cardiologists aren't patient, by nature, and this is one of those things where I think it's going to take a few years until we not only have trials ongoing, but results that can change the way we're reimbursed and hospitals are reimbursed.
Okay, well, there we have it. Any final words from our panel? Any take-home messages you want to share with our listeners? Any advice you want to give them in terms of using IVUS for their procedures? Maybe we'll start with Dan. Take-home message from your research.
So I'm really happy that we put this out there, and I think the point's been made. This is hypothesis-generating research, but it shows a pretty clear trend that there are improvements in binary stenosis rates, and maybe TLR rates a little bit farther down the road too. But it brings up the point too that I think we need more research in the space, more level 1 data to actually convince everybody else that this is something worth using. I think all believe on this panel.
Excellent. Sahil, final thoughts.
Well, I think it is important that we're trying to bring the level of rigor scientifically and otherwise to the practice of endovascular intervention. The peripheral interventionalists, those of us that are the stalwarts that are still out there, Herb's lost all his hair trying to convince other people that it's important for us to be interventional cardiologists still engaged in vascular intervention. But I like Herb, feel very strongly that we are able to bring to bear a different perspective than our surgical colleagues and our radiology colleagues. And it's important that in this multidisciplinary space, we stay engaged and we use these, principles that we've applied so effectively to coronary intervention, to endovascular peripheral intervention. And, it's obviously our mission, especially Herb's and mine and others, to train the next generation in the best practices for treatment of patients with vascular disease. And it's clear that these lessons we've learned in the coronary space are well applied in the periphery and are translatable back and forth. So, we want to inspire the next generation. There's a lot of opportunities for research, a lot of opportunities to contribute, and this is but one of many.
Excellent. Herb, close it out for us. Final thoughts about infrapopliteal IVUS.
Yeah, I mean, I would say for Infrapop IVUS, but really even more broadly, IVUS for even FemPop and just endovascular intervention in general. We've talked about how important it's going to be to have the evidence, and so again, we're all going to have to wait. But I think in the meantime, there's probably a lot we can do by partnering with industry to try to both make the technology more affordable. But I didn't mention it earlier. I think spend time on educating the cath lab staff and operators. Anything that we don't do a lot, we tend to have a little bit of maybe discomfort around, and it tends to take us longer to do, right? Things you do a whole lot of, it's second nature. You don't think about it. You have muscle memory and it's just easy, right? So I think we probably need to have more in-services and probably more reps in labs helping to train up individuals, or at least train someone who can then, a physician operator who can train everybody else. I think if we get to that level of comfort, we're going to see wider adoption of the technology.
Excellent. Well, thank you all. Thanks very much, Dr. Snyder, Dr. Parikh, Dr. Aronow. We are thrilled to publish this important paper in JSCAI and to share this discussion with an incredible panel. Please follow JSCAI. Submit your own work to JSCAI. JSCAI is the official journal of SCAI. You can find us online at jscai.org, on X and Blue Sky at @myjsci, on YouTube at SCAI-TV, on ViewMedi at JSCAI Journal, on Spotify and Apple Podcasts at JSCAI Beats. Thank you all very much.